Hello, everyone. We're just going to give a couple of seconds for folks to migrate in through the Zoom portal. So happy to have everyone here for our May edition of the Gender Equity Education Series. Happy spring in Vermont. I think it is officially spring. The daffodils are blooming outside my window. So today we are so pleased to have Dr. Sumner here with us to continue our discussion about intersectionality and with a highlight on disability in the scientific workforce. And I will introduce Dr. Sumner in just a moment. But first, if you've been with us for the last couple of months, you know that we've had community members speak about their experience of gender equity at our College of Medicine and speak about what they're doing and what we should all be doing to foster an environment that's equitable, just, and fair. And today we're very lucky to have Michelle Bookless here with us. She's a longtime staff member who is the digital content manager at the Larner College of Medicine Office of Medical Communications. She has a particular interest in equity and representation within digital content. And she completed in 2019 to 2020 the Office of Diversity, Equity, and Inclusion's certificate program, where she forwarded some of these ideas around representation. And so I'm going to give Ms. Bookless the floor to speak for a couple of minutes. Thank you so much for joining us.
And thank you so much for that introduction, for having me here today, Dr. Doherty. Good afternoon, allies, accomplices, colleagues, and can you hear me? Okay. Let me try that again. Good afternoon, allies, accomplices, colleagues, and of course, our esteemed guest, Dr. Sumner. Before I begin, I wanted to acknowledge that today and this month hold significance for many of our colleagues and community members. Today is the 12th day of Rizwan, a Baha'i holiday and festival. Last night marked the end of Ramadan and the beginning of Eid al-Fitr, a religious holiday celebrated by Muslims around the world. The month of May is also Asian American and Pacific Islander Heritage Month, Jewish American Heritage Month, and Mental Health Awareness Month. So why do I start these comments by mentioning these observances at the beginning of a gender equity lecture? Because when we talk about gender equity, we must also talk about class equity, racial equity, religious equity, equity in terms of ability and sexuality, equity across all the various individual characteristics we may hold as human beings, a way of thinking about equity and how we address it that was highlighted and brought into the conversation by Professor Kimberly Crenshaw when she coined the term intersectionality in the late 1980s. It was a term I hadn't heard about when I first came to UVM. If I were speaking at this event back then, I would not have known about Rizwan or Eid al-Fitr. I would not have worried about how to pronounce these words correctly, watching YouTube video after YouTube video to try and pronounce them correctly. As a cisgender white woman, an American citizen, and a college graduate, to name only a few of my identities, I had and have a large amount of privilege and much to learn due to that privilege. As I began to learn more through interactions with our medical and graduate students and colleagues, many of whom are on this call today, I became aware of that privilege, my inexperience, my large gaps in knowledge, and as a result, my inaction, and often the unintentional yet very harmful and real discomfort I caused in my interaction with others. I learned that with my privilege comes a responsibility to act within my sphere of influence to impact positive intersectional change. But how and what is my sphere of influence? Enter Tiffany Delaney and the Finding Our Common Ground certificate program, a 10-month program I took part in, which Dr. Doherty noted between 2019 and 2020. The program's goal was to provide cohort members, a cross-section of learner, med, faculty, and staff, with the education necessary to explain how complex relationships between systemic racism and social identity affect campus climate and interpersonal interactions, and most importantly, to take the skills and knowledge learned through the program and implement them within our spheres of influence at Larner and beyond. The program was a turning point for me and one of the most impactful experiences for me professionally and personally to date. It led to my involvement with the Medical Student Social Justice Coalition and in my sphere of influence as a communicator for our college to actively consider the numerous and overlapping identities of our community members each and every time I create content. The Merriam-Webster Dictionary defines communication as a process by which information is exchanged between individuals through a common system of symbols, signs, or behavior. Yet based on the various identities they hold, individuals may have many different systems of symbols, signs, and behaviors through which they communicate. Through the program, I learned to be aware of my own biases, that what I viewed as common may be uncommon, unknown, or differently understood to and by members of my audience. I learned to be mindful of the fact that the symbols, signs, and behaviors that have long been seen as quote unquote acceptable are in many cases racist, sexist, ageist, ableist, classist, or otherwise discriminatory. As a communicator, I have access to powerful tools, including social media, websites, and email that allow me to share these messages instantly and with a very broad audience. The use of these tools comes with a great responsibility to ensure that the words, graphics, and icons within the messages I create don't harm, isolate, exclude, or endanger any member of my audience, regardless of intent. In a world that relies heavily on digital content and social media, choices about emojis, GIFs, trending hashtags, pronoun use, stock photos, alt text, image descriptions, captioning, and more impact those around us quickly, regularly, and lastingly. Within my role at the college, I'm working to help others think about how digital content can and does harm, and how actively engaging in practices that interrupt and halt this harm, both within our personal and professional use of digital modes of communication, are so important. Next time you think about posting to social media or sending a community-wide email, think about whether the content is accessible to those who are deaf or hard of hearing, blind, or have vision impairment or low vision. Consider the graphics or music you're using and whether they may be viewed differently than you intended. Remember that impact matters more than intent. Also ask yourself why you chose a photo and how your ingrained biases may have played a part in that decision. Consider how your choice of words or a trending hashtag may cause your audience or your subject harm based on the various identities they hold: gender identity, gender expression, sexual orientation, age, race, ethnicity, religion, socioeconomic status, educational level, or more. How can you continue to educate yourself about identities you don't hold and encourage others to do the same to inform these types of decisions and questioning yourself? There are countless resources with which to do so at UVM and within our college. Next time you're walking in Hale Gallery or the Given Courtyard, take a moment to watch the digital displays. There are often descriptive slides about upcoming cultural and religious observances, awareness days, weeks, and holidays. Centers, offices, and committees, such as our very own Gender Equity Steering Committee, the UVM Office of Diversity, Equity, and Inclusion, the Women and Gender Equity Center, the Prism Center, and more around campus offer free lectures and seminars. Learn, act, reflect, and then learn some more. Thank you for your time today, and special thanks to Dr. Ann Doherty, who invited me to speak today, Tiffany Delaney, Jennifer Knockber, and my colleagues from the certificate program and the Medical Student Social Justice Coalition, without whom I would not be where I am today and who I continue to learn from and be inspired by every day. Now I can't wait to hear Dr. Ann Sumner present.
Thank you so much, Michelle, for those words. And thank you for the personal work that you've done and the translation into your professional life. I think you're so right that when we're putting things out into social media, we have to be really considerate, just as we are with our words on a when we're interacting personally. So thank you for all the work you're doing to represent Larner College of Medicine in an equitable and just way. Thank you so much. Now, I have the pleasure of introducing Dr. Sumner, who will be speaking this morning. Dr. Sumner is a senior investigator at the National Institutes of Health. She's the section chief of ethnicity and health and the founding director of the NIH Rwandan Health Program. She holds degrees from Brown University and the University of Pennsylvania College of Medicine. She has dedicated her career to improving detection and prevention of diabetes and its complications in people of African descent. And she works with working with African immigrants. She and her team conduct studies which improve the detection of diabetes on the African subcontinent, on the African continent. She is an award-winning mentor. She has trained scores of scientists from underrepresented backgrounds. And in addition, she's dedicated to improving opportunities nationally and internationally for people with disabilities. Her efforts have led to a more diverse workforce at NIH. And her reach is expanding because since 2001, she's serving on the NIH Board of Scientific Directors, the NIH Equity Committee, and the NIH Disability Engagement Committee. I was privileged to meet Dr. Sumner at a Women in Global Health conference in Rwanda, in Kigali, Rwanda, just before the pandemic, and to hear her speak about the intersection of gender and disability and within the global health arena. And I'm so happy that we've been able to have her come and speak with us today from her office in Bethesda, Maryland. So I'm going to pass this over to you, Dr. Sumner. And before we start, just one note is please use the Q&A feature for questions. We'll have a Q&A at the end of Dr. Sumner's comments. And also this will be recorded and will be posted to the Office of Diversity, Equity, and Inclusion's website within a couple of days. Dr. Sumner.
Okay, well, thank you so much for the high honor of being here and the opportunity to speak. I'm really thrilled. So my slides should be up. Can you see my slides? I hope you will say yes.
Yes.
Okay, great. Now I have to rearrange this screen because okay. So, so first I want to say thank you to, let me just move these things, these announcements. Okay. First, I want to say thank you to Agnes Ben-Hawahu, who invited me to speak at the Women's Leader in Global Health meeting in Kigali, Rwanda. I thank her because this was the first time I spoke professionally at all about being disabled, and it was actually in an international forum. And I was quite concerned about doing this. This is very personal. It could be very painful. And I was actually afraid of crying. But I didn't cry. I did fine. And that's actually why I'm here today. But I just want you to know that speaking publicly about issues that affect you personally can, in fact, be quite difficult. Then I want to thank Patrice Allen Gifford, because a few months ago, I was invited by the NIH Executive Secretariat to speak about the experience of being a disabled scientist at NIH. And I said that I would, but that I would also tell the truth exactly as I had experienced it. And again, that gave me another voice and an opportunity, and that's what she asked me to do. So that talk will be the basis of the talk that I give today. And I'd like to thank Ann Dougherty for inviting me, and Tammy Comito for making this meeting so positive. And okay, next slide, please. My slides are frozen. Oops, no, okay. So I'm going to talk about my experience in philosophy with diversity, inclusion, and disability. I'm going to tell you that I'm from intramural NIH. So the NIH has 19 institutes. 10% of every institute budget is for studies and work to be done on the NIH campus intramurally. So that's where I sit. And so that you know what I look like, And in here I can laugh, and I am in a wheelchair in Rwanda at a meeting. And here, if you haven't had giraffes feeding out of your hand, you haven't lived. And you can see that I dress up just fine. So I'm honored to be an NIH employee. I'm infinitely proud to be an NIH intramural investigator. Intramural NIH is promoting diversity, equity, inclusion, and now accessibility. Adding the A to DEI means accessibility is a value and a right, and the A gives people permission to ask for help and expect help. So I'm having trouble with my slides. I'm not able to advance. Okay, so I'm going to stop sharing for a moment and then I'll share again.
Can you use your arrow key to advance?
Okay. Nothing, it's just totally frozen. Okay, so let's do this. How about, okay, escape. My computer is frozen. I've never had this happen to me. Wow.
Do I have the slides?
You should have the slides. Okay, task manager.
Give me 1 second. I'm logging in to my email.
Okay, so. Okay.
I think, Anne, I only have that video.
Okay, I sent it, but in task. Let's see. We will solve this quickly, I'm sure. Okay. Okay, let's do this. There's nothing like being flexible. Ooh. Okay, cancel. Okay. So I'm going to share my slides again, my screen again, I hope. Wow.
Technology is challenging.
Okay, so let's see here. All right, so can you see my screen now?
Yes.
Okay, so I'm going to I think that I'll be able to advance the slides if I do it from this vantage point. And I think we should just work with that, if that's okay with people. Okay, so you see I dress up pretty good. So the A gives people permission to ask for help and expect help. But intramural NIH has had a problem with reasonable accommodation and accessibility. The 30,000 employees in intramural NIH on May 26, 2021 got this email, and on December 17, 2021 got this email. And both emails said, notice to employees, EEOC findings of discrimination at NIH. The first case, May 26, 2021, said that recently we had a finding of discrimination on the basis of disability, and they had to offer reinstatement with reasonable accommodation plus post this notice. On December 17th, 2021, they said recently we had a finding of discrimination based on disability reprisal and of subjecting an employee to a hostile work environment when their request for reasonable accommodation was denied. So I don't know these people or the challenges they face, but I do know that their cases had to be incredibly strong, that the presentation of their cases had to be excellent, that the emotional cost, I say, is high, not just was high, because even after winning, the cost is high to the person who went through the experience, because keep in mind, these cases take years to resolve. But I also know that the National Institutes of Health continuously works to change and improve. and that it's a privilege to work in intramural NIH, and that I came to NIH in April 1998 as a staff clinician, and September 2011, I became a tenured investigator. So that's the background for this talk. So I'm going to talk about diversity, inclusion, and disability and how they are interrelated. And this is the official opening. And I'm going to tell you about my quote for the Unite campaign. The Unite campaign is a campaign in intramural NIH to promote diversity, equity, inclusion, and disability. And they invited me to become part of the campaign, I believe, because I am disabled. And then they asked every NIH person that was included in the campaign to provide a quote. But it was only my quote that was used in the program, and it's used everywhere to introduce the Unite program, everywhere it's advertised. And that quote was, "At the National Institutes of Health, Hope, and Humanity, all are welcome in our ranks and who we serve." And this quote has a history. So it's the National Institutes of Health because that's our name. And it's the National Institutes of Hope because Francis Collins always called it the National Institutes of Hope. Because at NIH intramurally, we study many rare diseases. I don't, but many rare diseases are studied. So it becomes a place of hope for many people. And the word humanity, I included the word humanity because I dedicate that word to Francis Collins. Because as you heard, I founded the NIH Rwandan Health Program, a country that was set with terrible war in 1994. But we started the NIH Rwandan Health Program in 2016. And every Rwandan physician at the end of the year, of their year at NIH, would go with me to Francis Collins' office and get their picture taken with him. It was a very special and important experience. But in 2021, NIH was intramural was almost completely closed down. Francis Collins was on the news all the time and incredibly busy, as we all know, with issues related to the vaccine. But I wrote to him on a Thursday in June at 8:55 in the morning, and I said, "Dear Dr. Collins, I understand how busy you are, but the Rwandan physician is graduating this year, and while all the other Rwandan physicians lived through a terrible time in their country, this Rwandan physician is a genocide survivor. If it would all be possible for you to have your picture taken with her, I would appreciate it so much." That was at 8:55 in the middle of the pandemic. At 9:05 a.m., I got an email from Francis Collins saying we would make it happen. And so here we are in his office, and here is the Rwandan physician just with Francis Collins. And we sat in his office for 20 minutes. And when he spoke with her, you would think he had nothing else on his mind but what was her interest and her future. It was incredible humanity. So there you have it. But there was a problem with the Unite campaign, and that is my picture was missing. They used my quote, but they didn't use my picture. And I had elected not to submit a picture just of my face, but my picture of me walking with my canes, because everybody says it's important for people to see people like themselves up there and doing the things that they want to do, but they did not use my picture. And I was actually quite hurt. But I kept trying to tell myself, that's all right, Anne. They used your quote. You're the only NIHer whose quote they used. They used other quotes from John Lewis, from Thurgood Marshall, from Jane Goodall. And I'm not putting myself in the same category as all those people. I'm just saying, NIH, put your quote next to them. Please try to be happy with that. But by not using my quote, though, I was part of the missing billion. The billion of people in the world that are left behind, left out, and not pictured because they're handicapped. And I wasn't happy. But I went to a meeting of the Disability Engagement Committee. Of course, it was a Zoom meeting, and I serve on the committee. And the meeting was on January 26, 2022. And members of the committee were complaining that there was nobody with disability pictured in the Unite campaign. So I said, okay. during the meeting, I emailed Dr. Sadana Jackson, and I said, we don't think it's right that there's no one with disability seen in these pictures of the Unite campaign. Within hours, they had this poster put together. By the next day, this banner was put up in building 31. Building 10 is the main clinical center building, but those flyers were already up. But now I was going to be featured in building 31. And the quote they put next to me, here's my quote, but here's a quote from Jane Goodall near my picture, which says, what you do makes a difference. And you have to decide what kind of difference you want to make. I was so pleased to be next to that quote because I want to make a difference. And I think that all of you in the audience want to make a difference too. And I believe that diversity includes disability. So that was really an example of people being called out and making a change because they could see it needed to be done. Now I want to go in another direction as well. And I want to talk about inclusion. I want to talk about inclusion from the perspective of racial and ethnic minorities in clinical trials as participants and as investigators. So my research, all of it is focused on early diagnosis and prevention of diabetes or cardiometabolic disease in African descent populations. So because of the protocols that I have led at NIH, I have between 1998 and 2022 enrolled more than 1,000 individuals of African descent into NIH clinical center protocols. At this level of recruitment, there are unmeasurable positive ripple effects because it demonstrates engagement and good feeling between NIH and the local community. Furthermore, I felt that I know I was combating vaccine hesitancy, both in the United States and Africa, because this was a marked outreach to the Black community in the United States, and African immigrants are in close contact with their brethren back home, their family back home. And everyone knows that one of the vaccines came out of NIH. So having a good feeling about NIH was so important at that time. And the way we know we're doing well with the community is that 1/3 of the enrollees in our studies are referred by another participant. One thing that's wonderful of being in intramural NIH is that I was enrolling healthy volunteers, but sometimes we discovered people to have important diagnoses they did not have, including a brain tumor, congenital glaucoma, severe osteomalacia, and so on. Every single person who enrolled in my protocols who were a healthy volunteer and did not have health insurance, we were able to get care for them at NIH, and that's a source of great pride. But also, because of the work that I've done, we've been able to add diverse investigators to our ranks in intramural NIH. And this is a measurable ripple effect because we were able to recruit underrepresented minority investigators because they have a direct interest in the topics we study or they want to study something else, but they want to be at an institution where they know the issues affecting their community are included, respected, and addressed. So these are the trainees that have been in my program. I've had 68 trainees between 1998 and 2022, and you can see the distribution of their ethnicity. So this is the protocol timeline for my specific protocol 99DK. 0002, and between 1998 and 2008, we enrolled African Americans. Between 2008 and 2022, we enrolled African immigrants, and we're hoping in the next 4 years to enroll African Americans, African immigrants, and African Caribbeans. And doing this has allowed us to have a great deal of outreach. So it's because of my work with African immigrants, I've been invited to speak in Africa about these studies. So in the 4 years before 2020, I was invited 9 times in 4 years to speak about our research on diabetes prevention, and I was invited to these countries. Then because of this, my work with African immigrants, I was able to start the NIH Rwandan Health Program. In 2015, Agnes Binouahu, who was then the Honorable Minister of Rwanda, gave the Barnes Lecture at NIH, and she asked to meet with me. 6 months later, we had the NIH Rwandan Health Program, with a Rwandan physician coming every year, one physician a year coming to work with me. This was the first physician. This is the current physician, and the 7th physician has already been selected. Because of my work in Rwanda, I was able to initiate in Africa my program called Grip the Ground. I would like to say that if you are a person who walks with canes, who's 100% dependent on canes, you can have canes that are cane tips that are worked all the way through to the bottom, because then you will fall down. And I can tell you throughout Africa that, and in other low and middle income countries, people have canes because they are durable goods. But what happens is these cane tips wear through. And if you have worn through cane tips, you can't stand up, you can't walk. And if you do, you will fall down. What you need are cane tips that are strong and sturdy. So throughout the different trips that I made, we would stop and we would distribute these cane tips to people everywhere where we would see them. This is a priest from Rwanda that I met at the Rwandan embassy in Washington, D.C., distributing the cane tips to schools throughout Rwanda. And this is Dr. Damas Kabakambira, who was the 2nd Rwandan physician to work with me. And we set up a program at the hospital where he worked, where this woman, who was just so excellent, distributed over 100 sets of cane tips. And we were keeping track what the diagnoses were, what the need for the people. And this was a person who both worked at the hospital and needed the cane tips. We were really having an impact, but we had to stop the program because of COVID. And I hope in 2023, we can restart it. I'm always in support of my disabled colleagues wherever I go. And both these people, we had a great time together. And of course, they loved the cane tips that I gave them. This is the Haitian amputee soccer team. That's where the need for cane tips really became evident. And there are many people with amputations in Haiti because of the 2010 earthquake, where extracting people from buildings sometimes required amputations. This Haitian artist created this painting for me because of my fundraising efforts, and it says, "Peace tips protect." People who are using these cane tips understand that they're desperate need. And that has led me, the Grip the Ground program in Africa led me to international advocacy, because that's why Dr. Agnes Binouahu invited me to chair a panel on health equity and healthcare access for women with disabilities at the Women Leaders in Global Health meeting. And at the end of the meeting, the call for action statement said, it emphasized that the global health institutions needed to anyway, whatever that word is, healthcare, handrails, ramps, and canes. And actually, I'm gonna give the remarks that I gave as my opening statement at that meeting, because that's why Ann Dougherty wanted to meet with me. And I said, my primary focus is on cane tips and handrails and ramps for people with mobility impairment. Throughout Africa, I see people, men and women, walking with canes and crutches with cane tips that are almost worn through. This means there are people at home unable to walk because they do not have access to cane tips. Cane tips provide freedom, opportunity, safety, and independence. But the need for this vital, inexpensive, and urgent resource is rarely discussed. Another inexpensively remedial problem is the lack of handrails and ramps in schools, stores, staircases to roads, and public transportation. This same issue exists in healthcare facilities. Many healthcare facilities, I would say all healthcare facilities which I have visited in Africa, do not have handrails or ramps. If there are elevators, they often do not work. Therefore, patients are carried between floors. This is humiliating, unhealthy, and dangerous. In short, often people with disabilities cannot get to the healthcare facilities, and once they get there, cannot gain safe entrance to get the care they need. And then there's particular relevance to women with disabilities. The issue of lack of cane tips, handrails, ramps, and elevators are relevant to women with disabilities because first, women are supposed to be caregivers, not receivers. And if they cannot get into a healthcare facility, they can neither get the care they need, nor can they care for their children or relatives at the facility. Second, if women need physical assistance in the absence of cane tips, handrails, or ramps or elevators, being carried by men who are not their relatives is very problematic. So I'm here to champion access to cane tips for women and men with walking impairments, the building of ramps and handrails in hospitals. And I believe that hospitals and clinics with steps without handrails should not be receiving government or NGO funds. This is a remedial deficit that if there was a will to fix, it could be fixed. And so here I am at a hospital, and you can see there's no handrails. And these are other steps, no handrails. And I didn't want to go up and down these steps in front of people because I didn't want them to see me do it. And I didn't want them to realize that it would be embarrassing for my host to see how difficult it was, but it's how difficult it is for their patients. So at the end, we can show a video of me going up similar steps somewhere else if we have time. So these handrails, ramps, and canes can be instituted with little or no cost. And I would like to be known as the cane tip girl and the handrail honey. Now let's talk about McCary University and the Disabled Student Association. I visited the Disabled Student Association in July 24th, 2019, when I was speaking at McCary University, and these are the students that I met with. I went back in February of 2020, February 28th, 2020, 3 days later, the border closed, and who all knew that what would happen with COVID. But here I was with the disabled students, and many more came to visit me here because they heard about this visit. And I want to talk about the universality of the handicap experience by telling you what the questions were that the McCary students asked me. And yet what they asked me resonated 100% with my experience as being a disabled student scientist and doctor at NIH. One question the McCary students asked me was, why do they hate us? Well, you should know that people with disabilities get a lot of negative thought and action and feeling gets generated towards them, and they don't even know why. And speaking to my own experience, when I was an intern, the ER nurse told me that neurology nurse so-and-so hated me. And I said, why did she hate me? I never met her. I've never even been to the neurology wing of the hospital. And the ER nurse said to me, well, I told her that she could end up just like you, meaning I was using a scooter. And I said, why would you say something like that to her? And the ER nurse said, well, she has MS. And I said, oh, to myself, I said, she's afraid that she is going to end up in a wheelchair or a scooter. So she's directing all this negative thought towards me. But it's very difficult for all that hate to be generated towards you, especially if you're a disabled student and you're young. Now, another question they asked me, why are they so mean? And the example they gave me was this student, his class was on the 4th floor of a walk-up, and the professor would not agree for the classroom to be moved down to the 1st floor. And he didn't want to be carried up to the 4th floor. So he crawled up the 4 floors to go to his class, and his fellow students carried the wheelchair. That was mean. mean, and terrible. But it's not unlike my experience. In 1998, you see, I'm old. In 1998, I was a nutrition support fellow at the Hospital of the University of Pennsylvania. And that's a hospital that was built over 100 years. So there are 8 or 9 buildings that are built next to each other, and they have entranceways that go between the buildings. But in order to go from one building to another, if you can't take a single step because of the scooter, that means when I came into the building in Silverstein, to where I would have to go to pick up the list of patients I would need to see, I would have to take 9 elevators. And then to get back to where I would start seeing patients, I had to take 8 elevators back. That's 17 elevators. Do you know how exhausting that is? How draining that is? So I asked the physician running the program, I said, could I just call in the morning and get an update so I could get the update by phone? And he said, no, if I let you do it, everyone else will want to do it. So I said, yes, but they can walk. And he said, I don't care. And I said, that position is not worthy. And he said, you were on thin ice. So I said that conversation had to end. So the administrator took me over personally and privately and said to call him in the morning. He would help me out and give me the updated sheet printed out at lunchtime. So that was a terrible experience, but it could happen at NIH. So at NIH in 2007, we were moving to a new building. So I was told that they were going to give me a very special office. Well, when you're a handicapped person and someone tells you they're going to do something special for you, you need to start thinking, danger, danger, danger. So I said, oh, I would like to see this special office before I accept it. So the building was still under construction. They gave me a hard hat and I went in my scooter with the construction workers to see the office. And it was a beautiful office. It truly was. But so I said, well, this is great, but where is everyone else's office? They said, well, it's down the hall, but you can't get there from here. You have to take an elevator down, then go down the hall, and then up another elevator. I said, yeah, that's right now because there's construction. But after the construction is over, I'll be able to go straight down that hall. They said, no, never. It's going to be permanently blocked. So I said, let me see if I understand. So in order for me to go see my secretary, I need to go down an elevator, down the hall, up an elevator. Then I get there and I realize I forgot my glasses. So then I can go back down the elevator, down the hall, and back up to my office. And then to do the sequence again to see her, I will have taken 8 elevators. I said, you don't have to fix this office up for me. This is not going to be my office. I got back to my old office and I called an EEO officer that I know. I don't remember her name. I don't remember how I knew her, but I said, this can't possibly be my office. And she said, I agree with you. And we hung up. 3 minutes later, I got a phone call from my branch chief, and your office will be with everyone else's. I said, whoa. I called the EEO officer back and I said, what happened? And she said, in the first place, it was stupid to give you that office. And in the second place, it was illegal. It's illegal to put handicapped people separate. You know, we're all physicians here, but they were going to put me separate. So that was the end of that. But I want to say that hyper elevator situations are not reasonable and they are not accessible. And they may not be evident to you who looks at things in a map. So you need to talk to people who are living the experience. The next thing the McCary students said to me was, they accuse us of costing too much. But many accommodations, I'd like to tell you, cost nothing. If that professor for the person in the wheelchair would have moved his classroom from the 4th floor to the 1st floor, it would have cost nothing. And for me at NIH, I started work on a Monday in mid-April 1998. and my office wasn't ready. So they said, they gave me an office in a lab, but the scooter that I was using couldn't fit through the lab to get to where the desk was. So I had to leave the scooter in the hallway and walk to the desk that had a manual wheelchair. So that means I would sit, stand, walk, sit, stand, walk, sit, stand, walk 25 times a day easily because I was going out to see patients. That was Monday. By Wednesday, I went to the person who hired me and I said, I can't come to work tomorrow. I am so exhausted. I'm in serious trouble. But there is a way this can be fixed. If you look at all these bookcases and file cabinets in the hallway, they're all 6 and 12 inches apart. If you just would all put them next to each other, that would create a space for the wheelchair and the scooter to meet in the hallway. And then I would be fine. And the physician said, okay, but we'll call the government movers, but it can take weeks and weeks for them to come. I said, that's all right. Just tell them it's a medical emergency. They'll be here today. And they were, and they did move it, and it was all perfect. And that went on, and it cost nothing. So you have to have, if you're a supervisor, a can-do attitude to get these issues fixed. Now I want to tell you that space and health are 100% linked, and I'm getting a little hoarse, so excuse me. I worked at NIH. I worked at NIH for 10 years, from 1998 to 2008. And I had agreed to so many things that I could barely do physically, but I wanted to get along. But by 2008, I was so exhausted that I was afraid to walk. I was afraid with each step that I might fall down. And I knew there was nothing wrong with me that rest wouldn't fix. But I also knew if I fell down and broke my arm, rest wasn't going to fix that. So I asked for help. I asked if the people working for me could be in the desks across from me instead of elevators away. And I was told no. I realized that I had to quit. But the situation was described to the deputy director of intramural research, and it was fixed. And because of that debacle, that was 2008. In 2009, I was invited to speak to the scientific directors. And I told them we needed 3 things. We needed accessible office space for the scientists and accessible space for their trainees. We needed longer time on the tenure track and between Board of Scientific Counselors evaluations. And we needed increased funds because, for example, we had to stay at the hotels that were immediately adjacent to convention centers and not a shuttle away. This was approved at this meeting for all persons with mobility impairments in NIH. The only problem was that I was the only one that knew about them, so they only applied to me, and that wasn't satisfactory. But by 2021, I had been invited to join the board of scientific directors at NIH. In 2021, NIH made a ruling that there would be 4 people on the board of scientific directors who were not scientific directors, but would be full voting members. And one of those people was me. And 14 years later, those rules now apply to everyone at NIH with a mobility impairment. It was worth the wait. So you have to be at the table or you are missing. And so committees that I currently serve on at NIH are the NIH Equity Committee, the Disability Engagement Committee, and the NIH Board of Scientific Directors. And I think to the greatest extent possible, do not advocate for yourself, advocate for the group to which you are a member. So that's my experience in philosophy on diversity, inclusion, and disability. They're interwoven. And I'm infinitely proud to be an NIH investigator. Remember, I gave this to the NIH Executive Secretariat, and this is true. And adding the A to DEI means accessibility is a value and a right. And the A gives people permission to ask for help and expect help. And asking for help should not be a fearful, perpetual, alienating experience. And I can tell you that it remains at times even that way for me, because our offices are moving again. So we'll see what happens. But nonetheless, we move forward. I want to tell you about the awards that I've gotten, because these are awards given by NIH. And I want to tell you that as you have your programs, it's really, really important to give awards to the people on your staff and in your school that are making a difference, because they inspire confidence in the awardee, because it is not easy to speak up. It's much easier for me now, but it's still not always easy. And these awards lead to community respect, and that makes them very important. So over here are the awards I've gotten since I've been at NIH for diversity and inclusion. And here are the awards I've gotten for mentoring. So thank you, everyone. And I will stop sharing my screen.
Thank you so much, Dr. Sumner, for sharing your personal reflections. I deeply appreciate I think the courage and the vulnerability that it takes to bring this experience to an audience, and also feel like I benefit so much from hearing about your experience. And one of the things I was thinking about was the regulations for around accessibility, and certainly they're building codes around accessibility to some degree, but then thinking about what it actually means to create a truly accessible environment, which goes beyond satisfying codes.
Codes just mean people may be able to enter the building, but that doesn't mean that it's actually usable by people with disabilities. So I had a meeting with someone about making labs accessible, and I can't really speak to, since I'm a clinician and a physician, I can't how lab benches should be modified. But the guy was saying, well, we have these door handles, so now we're fine. I said, no, that just means that someone can open the door. It doesn't mean when they get through the door that the lab is accessible. And then also this hyper elevator situation is really a problem. And so you need to have people who are living the experience tell you about that, whether or not that situation exists, because there has to be a modification on location if a hyper elevator situation exists. Hyper elevator is my word, and I really like it because it really explains what's going on. But you don't know it unless you live the experience. A lot of people tell me, I was on crutches, and so now I understand better. I say, you were on crutches and you understand better, but I don't consider people on crutches because they broke their foot to be disabled, but I consider them to be temporarily inconvenienced. And I hope they do remember what it was like.
Absolutely. I would offer that folks can use the Q&A function if they'd like to ask questions or if they have comments, and we will take those questions. I also wonder about, and this is not just about people with disabilities, it also pertains to anyone who's underrepresented in medicine and science, but what are the, besides accessibility, what are the mechanisms that you think of to help support and retain investigators from underrepresented or marginalized backgrounds?
Continued support, and having a good mentor makes all the difference in the world. And expecting excellence, so that people, and being consistently excellent and asking people, when students start with me, post-bacs right out of college, they don't understand that this is a job now. This is not, you can't just show up when you want to, that we're doing medical care and medical research, and you have to hold yourself to the highest standard. So you have to create an environment where everyone is holding themselves to the highest standard, so that people will reach for those stars. And that's very helpful by creating that environment. And also explaining to people, here at NIH, we don't have a dress code, but we have a dress code for my group on days that we see patients. You can't wear blue jeans. You can't wear, you can't have sunglasses on your head. You can't have a baseball cap on, because I don't care how the patients come to the clinic. That's not how they have to see that we hold them in the highest respect. So that leads people to want to be part of our program.
That's great. That's great. And I wonder about the students with disabilities at McCarey. You know, I like that you draw the parallels between their experience and experiences that you've had in the US. And I was thinking about things like, yeah, why, when you live in a major city, are subways not all handicap accessible? And why are there not curb cuts that are everywhere? And what does that communicate back to the person with a disability about how they're valued in that setting? And I think it's very dramatic in an under-resourced area like Uganda, but also it's here in the US as well, in major cities.
Right, and it doesn't have to be. This one McCarey student was telling me that his father had polio and he couldn't, in order for him to walk to see his son graduate, he ended up having bloody arms because they didn't have a wheelchair and they wouldn't let the taxi drivers that drove motorcycles bring his father up to where the graduation site was. It was all completely unnecessary. There's not, if I were to become faculty somehow at McCarey University, I would use my voice to change that. And I think that we all have to become voices for people.
And we have some questions from the audience. One of them says, in your view, how do we, hang on, how do we embrace researchers with disabilities, and what do you think the roadblocks are for people with disabilities to achieve their scientific goals in the US?
Well, that's a very, very large question. I was recently at a meeting where it was about the Deaf Institute, and they were asked whether they provide outreach to Gallaudet University, which is here in Washington, DC, and it's the only university in the United States, which is an undergrad university devoted to deaf students. And the Deaf Institute said, we're too small an institute. And I said to myself, if you're not going to advocate for deaf people, who are? So it's an attitude that's so difficult that is the leading problem. That if people were willing to find a way, it would be possible. And I think there is the concept that it's going to be so expensive. And that's why I brought up that issue. It doesn't have to be expensive. There's many things that can be done that can make it possible. So there has to be people who believe that it's possible. There has to be investigators and senior scientists who believe that it's possible. And that's what people invested in me when I was young, even before the Americans with Disabilities Act, to make it possible for me. And I would like to say that physician who wanted me to take 17 elevators to do my job every day, he couldn't do that after the Americans with Disabilities Act, but somebody that mean would find another way to make it incredibly difficult or almost impossible for me. So I think we have to, that it's an individual responsibility. So.
Thank you so much, Dr. Sumner. We have more questions. There are more comments, and and we've hit the 1 o'clock hour. And so unfortunately, we don't have any more time. I think we should invite you back to go through some more of these questions at another point in time. But thank you so much for sharing your experience with us, for deepening my understanding of life with disabilities in the scientific workforce, and for sharing your perspective. And thank you everyone for being here today. Remember that this was recorded and will be posted on the Office of Diversity, Equity, and Inclusion's website. Just give us a couple of days to put it up. I want to thank Jordan, our captioner, Bruce Kimball, and the ComAV team for all of their support. Tiffany Delaney, always, for being a superhero, director of our Office of Diversity, Equity, Inclusion. Tammy Candido, our administrative assistant, who has since left us. Leanne Holterman for helping out with questions. Michelle Bookless, thank you for your words at the beginning. On June 6th, we're going to be hosting a town hall style presentation. So come join us June 6th, 12 to 1. And bring your thoughts on gender equity and your wishes and your hopes and your solutions, and we'll have a great discussion. Thank you so much, and take care.
Thank you.